Thanks, Sarah. So I really just wanted to welcome everyone to the webinar this morning and to introduce Dr. Stephen King, who's going to be doing our presentation today. So Dr. Stephen King's been a commissioner with the Productivity Commission for 3 years and is also a professor in economics at Monash University in Melbourne. Before that, he was a member of the ACCC, the Australian Competition and Consumer Commission, and his main areas of expertise are really microeconomic theory, competition economics, regulation, and industrial organisations. And obviously his research has been published widely. So Dr. King has recently completed the inquiry into economic regulation of airports and is currently presiding commissioner for the inquiry into mental health. But today he's here to talk about the Department of Health independent review of pharmacy remuneration and regulation that he chaired. So the final report for this was provided to the Minister for Health in 2017, and the review's focus was really to ensure that consumers have reliable and affordable access to medicines. But I'm really looking forward to hearing Dr. King talk about a bit more behind the scenes and what actually happened in the review. So as Sarah mentioned, if you have questions throughout the presentation, feel free to write them in the chat or the Q&A section, and I'll keep an eye on them. And at the end of the presentation, I'll go through and we can have a discussion and people can ask questions. So thank you, Stephen.
All right, thank you, Alison. Let me just start that way. Okay, so just a little bit of background on this review. One thing to make clear, it was a Department of Health review rather than a Productivity Commission review. So the process was quite different from a standard Productivity Commission review. It was an independent review. It was a review commissioned under the 6th Community Pharmacy Agreement. And for those of you who don't know what they are, I'm going to discuss them a bit later. This is the 3 panel members. So Bill Scott on the left of screen. Bill, a very respected long-term pharmacist. And was provided incredibly valuable input into the review with his expert. Joe, a member of PBAC and also Consumer Health Forum. And I'm the economist in the centre of this, trying to make sense out of the medical material. So what do I want to cover very briefly on these slides, or very quickly, in the next probably about half an hour, 35 minutes. What were we asked to do? A bit of background and history of pharmaceutical system in Australia, so that I'm not going to assume background knowledge. What our analysis was, our recommendations, and then I'll turn it over for some questions. So firstly, the scope. What were we asked to look at? So the panel was asked to consider pharmacy remuneration for dispensing, the regulation of pharmacy, the supply chain of the pharmaceutical system, so how the medicines get from the manufacturers to the pharmacy to the consumer, the systems of accountability that exist for pharmacies and also for wholesalers, but I'm going to concentrate on the community pharmacy sector today. And most importantly, the consumer experience. I want to stress the consumer experience here, because as an outsider, as an economist who has done a fair bit of work in health in the last 5 years, but up until that point, had really been dealing with issues of competition, more familiar with banking and telecommunications and medical systems. The idea of a consumer-centred health system is a no-brainer, to put it simply. And for an economist, it would be hard to imagine anything else. The whole point of the health system is to maintain and help consumers live healthy, happy lives. So our inquiry very much came from the consumer back to the system. One of the interesting things of getting involved in medical or reviews relating to things like pharmacy, to mental health, some other areas that I've been involved in at the Productivity Commission, is that that idea of consumer-centred seems to sometimes be radical, at least to some of the people in the profession. Sometimes it seems to be that the medical profession has the view that it's a system that should be run for the medical professionals. And I think pharmacy creates that tension. There are at least three groups in the pharmacy, the community pharmacy supply chain, or that part of the supply chain, that we need to consider. And they're going to be the consumers, they're going to be the pharmacists, and they're going to be the pharmacy owners, who, whilst they are pharmacists, have very different interests to the people who do most of the dispensing and most of the serving of the consumers. So keep that in mind throughout this talk, that we've got these three groups. The Pharmacy Guild represents the pharmacy owners. It doesn't represent the employee pharmacists. The Pharmaceutical Society of Australia, the PSA, it represents the individual pharmacists. It's one of the representative bodies. There's also a union. And our aim was to make sure the system was working for the consumer. And some of the conflict that you'll see, not just in our recommendations, but within the panel, did reflect that. And so if you want to go back and see the history of this review and to see the areas of tension, quite frankly, and then to look at the final report. The draft report was much more adventurous than the final report. The recommendations, the draft recommendations, quite frankly, pushed the envelope a lot further. They got pared back to a large degree. We wanted to have consensus on our recommendations. But that did in the panel and in the makeup of the panel. So that's one of the things to keep in mind. Going back through the recommendations as I have in the last few days, just both the final report and the draft report, it would have been nice if we could have got more of the draft report recommendations agreed to by all the panel and up. The draft report, there was agreement to put ideas out, but we had a lot more trouble getting consensus to put those same ideas or improved ideas up to the government. So a bit of background, a bit of history. Sorry for those of you who are involved in the pharmacy industry. You'll say, well, you know, this is well known to you, but I don't want to assume background for all of the people viewing this webinar. Very simply, and the diagrams here come from the draft report, and I've just popped them in the slides here. Three real stages to the pharmacy supply chain in Australia. There's the manufacturing side, which is the drug producers, AstraZeneca, for example, Pfizer, and so on. Many are names that you'll all be familiar with. And we're going to be talking here about PBS, in general, PBS-listed medicines. So these will be medicines that the Australian government has determined need to be listed under the PBS, and in certain situations will be subsidised by the Australian taxpayer through the PBS to make sure that they're affordable medicines for all Australians. So we're starting off with the PBS medicine manufacturers. There's then a distribution channel that has to get those medicines to the community pharmacy. And then the community pharmacy is the connection to the customer. The consumer receives a script, could be from a hospital, but more generally from a GP. There are also other parties that can prescribe. The consumer will take that script to a community pharmacy to have that script filled to receive both the medicine and the other services that need to be supplied with that medicine. So again, one of the things to keep in mind is that we need timely provision of the medicine. So that's where the distribution channel and the wholesaling comes in. And we need safe dispensing, and dispensing is a group of services that will occur at the community pharmacy. Who own these community pharmacies? Well, legally, community pharmacies are owned by pharmacists. Often, a number of pharmacists will own a pharmacy. Pharmacists can own multiple pharmacies. The actual number of pharmacies that a pharmacist can own depends on the state that they're in. Pharmacists who can own different pharmacies in different states, and they can, and there are some who will max out the amount of pharmacies they can own in a number of states. There are some independent pharmacies which come under the other group, but many pharmacists work through what are called banner groups, or more generally, you can think of them as franchise arrangements. These franchise arrangements or banner groups are often closely connected to the wholesalers and have connections back into the wholesaling, the various, the three main wholesalers. Just to give you an idea of the market shares, at least when the draft report came out, we had API, which I think Priceline, at about 10%, Terry White Chemmart was about 12%, Sigma about 19%, and My Chemist, which many people know as Chemist Warehouse, around 20% of the ownership. So this is the count of pharmacies. The count of pharmacies doesn't directly reflect the number of scripts filled. So if we look at number of scripts filled, then the share going in particular to the My Chemist group goes up substantially. So the best information we had when we were doing this report was that the My Chemist group accounted for probably about 30% of dispensers. So even though it had about 18-20% of pharmacies, it accounted for a lot more of the actual dispensing that occurred in Australia. Now, I mentioned before that the dispense is a mix of services, and it's important to keep this in mind. When preparing this talk, it reminded me of something I heard from Customs stated on about the job of customs officials at airports once, which is they have to go through an awful lot of dirty underwear in order to get the kilogram of cocaine being smuggled into the country. In a sense, dispensing is a bit like that. There are many very simple dispensers that occur in community pharmacy. However, the real role of the community pharmacy and the pharmacist in the dispense is to make sure that the non-routine dispensers are done properly and are done safely. So what do we mean by that? There's a couple of examples here. The slides will be up on the website afterwards, so no need to try and read them now. And these are, again, straight out of the draft report. But a simple example given at the top, there's a new script. The consumer goes to the pharmacy. It's their regular pharmacy. They pass the script over to have it filled. The pharmacist can check up their records and see what other medicines this consumer is on. And they may note that there's a potential medicine interaction between the patient's existing medicines and this new medicine that their GP has suggested they go on. They will then discuss that with the consumer. They may ask the consumer's permission to ring the GP. They may ring the GP and check, is this right? Was the GP aware of the potential for the medicine misadventure? Most likely the answer in that case will be no. The GP will then may change the recommendation of a script. The patient will then need to go and get the paper script before it can be filled. So the patient may need to go back to the GP, get the script, come back to the pharmacist, and have that script then safely filled and be able to take them. Part of that safe filling of the script and getting the medicine, the consumer may need information about how to take the drug, about potential side effects. In certain situations, the consumer may not feel about discussing that simply at the counter at the dispensary, so they may move off to a small consulting room off to the side to do that dispense. So, in a sense, that example is a situation where the pharmacists really, where they add value. And pharmacists community pharmacists save lives. And we should never forget that. It is an incredibly important profession and they protect consumers. However, as I said before, you go through a lot of dirty underwear to get the drugs at customs. The vast majority of scripts that are filled are fairly regular, simple sorts of processes for the pharmacist. The actual dispensing process is becoming easier in the sense that get the right medicine with machines that are now included in some community pharmacies. So you can think of them as a safeguard. Just a couple of bits on that example that I ran through. A couple of parts need explanation because they will fit into some of our recommendations. Firstly, I suggested that the pharmacist, if the consumer didn't want to discuss it at the counter, there may be a consulting room off to one side that the consumer and the pharmacist could go to discuss in private. Not all pharmacies, not all community pharmacies have such areas. Where they do have such areas, sometimes they're pretty basic. There are a range of differences between community pharmacies, not just in what they stock front of counter or outside the dispensary, but also how they carry out the job of dispensing the medicines. And I'm sure we've all come across a situation where there's a queue at the dispensary, it's lunchtime, it's a busy dispensary, and they're working hard just to get the medicines out and to avoid people waiting excessive lengths of time to get their scripts. And that may lead to some of the care, some of the checks being done quicker than we would hope. You can also be in a situation where you will go with a script to a pharmacy, and we had examples where the pharmacy will refuse to fill that script. And that's slightly odd. Pharmacists quite correctly say that they're agents of government in the supply of PBS medicines. So it does seem odd that you can sometimes be in a situation where you go to a pharmacist with a script and the pharmacist says, well, no, I won't provide that medicine. And morning after abortion medicine is an example of that sort of service. It can be situations where necessary equipment that you need, such as sterile syringes, in order to administer the medicine, aren't sold by the pharmacist. So one of the things that we saw in this inquiry is a range of standards for pharmacies and for dispensing, even if we think of behind the counter. And that's going to feed into some of our recommendations. The second bit I want to highlight is the paper script. The paper script is the required record for the pharmacist to get the remuneration from the government for the medicine that they're dispensing. Without that paper script, you don't get the money. We were at a chemotherapy, a very, very large chemotherapy dispensary in northern Sydney, prepares a lot of the chemotherapy medicines for New South Wales. They had more people in a call centre chasing up medical specialists, often oncologists, to get the paper script sent to them because the way that they worked is that people would ring through, say, we need these medicines tomorrow. They would prepare them, they would ship them out, but formally they needed to get the paper script before they were able to receive the remuneration from the government. So these paper scripts, have real costs associated with them. There's also evidence from the medical literature about errors in paper scripts, and paper scripts are more subject to errors than, for example, electronic scripts. Payment. So just the last bit of background here. What do you actually pay for the medicine? Well, that depends. The numbers here, so this is out of the draft report, so the numbers here are slightly different. But we can think of the key points being this ex-manufacturer price down here. That's the price that the government would view as being paid by the pharmacist for the medicine. There's then a wholesale markup, 7.52%. That comes to the approved price to the pharmacist. There's then various fees added on for dispensing, and that comes up to a dispensed fee, which is a Commonwealth price. So that entire left-hand column, it's important to understand that entire left-hand column is determined by the government. Why is that important? Remember this ex-manufacturer price down here, $41.76 in this example. That is the price the government, in a sense, assumed that the pharmacist was paying for the medicine. It wasn't necessarily the price the pharmacist was paying for the medicine. If we go back to the early 2000s, there were many situations where, because the pharmacists, through the wholesalers, were negotiating for medicines with the manufacturers, that the price may have been less than 41. And in fact, a significant part of community pharmacy profits came from the fact that the government price was higher than the price that the pharmacy was actually paying for the medicine. So in that situation, let's say the pharmacy was paying $35 for the medicine. So there was immediately a $6.76 profit for the pharmacy on that medicine, plus the fees that the government was providing, for example, the dispensing fee and so on. So keep that in mind. The consumer comes in and it's dispensed. What does the consumer pay? Well, in this situation, the price, $55.32, is above the co-payments. The general co-payment, that's now gone up to $40.30. It was $38.30 when we did the draft report. If you're not a concession card holder or subject to the safety net, that is the maximum amount you would pay for that medicine. And in this case, that's the amount you would pay for the medicine. $6.20 was the concessional amount. It's now $6.50, and $0 if you're already under a safety net. The government then, of course, is actually paying the difference between what the consumer pays and this dispense price. So, and there's also a potential for other fees and charges that are paid to the pharmacist on top of that. So it's a fairly convoluted system of payments that are going on here. This is just another example. Here, the dispensed price comes to $14.25 with a $19.82 price to a non-concession consumer. That is not a maximum price, nor is it a set price. The pharmacy can set below that, it can set more than that, it can essentially set anything up to the general co-payment for a general consumer for that medicine. And again, that's something important to keep in mind. That, by the way, is the explanation for if you go into different pharmacies with the same script, you will sometimes receive different prices for that medicine. And that's because the pharmacy actually has the discretion to decide how much to charge in that case. It can charge more, it can charge less, it depends on what the market will bear. Bit of history. How did we get to where we are today? 1980s, we had quite a different approach to pharmacy. There were no location rules. The Pharmacy Guild existed, but there were a lot of pharmacies. Approximately the same number of pharmacies in the 1980s as today, but a lot fewer people. And Australia essentially had too many pharmacies. It had too many small pharmacies driven by government policy. Government had set up a remuneration scheme for pharmacies, which, to recognise economies of scale, essentially paid a fixed fee to pharmacies and then a fee depending on how many medicines were dispensed. What they ended up doing was creating an incentive for lots of small pharmacies to set up. The government wished to move away from that. It had an inquiry in 1988. It needed to reform the way it remunerated pharmacies, and it wanted to try and close down the inefficient pharmacies through either amalgamations or actually having them closed down. That led to the first CPA coming in the 1990s, Community Pharmacy Agreement. It's an agreement between the federal government and the Pharmacy Guild. It came about because of a problem with this process of reform that the federal government had embarked on. You can close down a community pharmacy in one location, but there was no rule against that pharmacist taking the government's money to close down at one location, renting the shop next door and reopening the next day. So if the federal government wanted to reduce the number of community pharmacies and compensate people for closing their pharmacies, it had to make sure that they couldn't just reopen them again immediately. And that's the basis of the location rules. So the initial location rules basically said, can't re-up a pharmacy with 5 kilometres of an existing. And it was to try and get around that gaming that occurred. Initially, the Pharmacy Guild actually opposed those rules. However, it changed its approach when it saw actually how valuable they were to pharmacists themselves. And the reason why they're valuable to pharmacists is that essentially you now have a set of rules that for any area that is growing and developing allows local monopolies. So it was grandfathered into urban areas. So if you go to, for those of you from Sydney, Melbourne, Brisbane, elsewhere in Australia, you will be able to tell me numerous places in Australia, in your towns, where there are 3 pharmacies in one street opposite each other within 100 metres and so on. They are grandfathered. So they were probably all in existence before the 1990s, subject to some movements, but I'll get to that. The key effect of a location rules, though, meant that in, for example, developing areas, the growing suburbs of outer Melbourne, the west of Sydney and so on, that new pharmacies, if they could get in there, got local monopolies. It also meant in country towns, in rural and regional areas, that you were able to get to local monopolies or local oligopolies. And that meant that consumer choice was limited. And you'll notice I've already mentioned that there's pricing discretion. It means that if you're in one of those poorly served areas, outer suburban of the city or rural and regional Australia, you often pay significantly more for your medicines than if you are located in the more established inner city areas. That's the consequence of these rules. Now, the Community Pharmacy Agreement covered dispensing, programs for pharmacists, and also wholesaling. With any sort of regulation like this, you get incentives to play the game. So one of the things that was immediately obvious very early on, and was one of the first changes to the location rules, is that if you had a pharmacy in a shopping area that was dying, for want of a better word, you were in deep trouble under these rules because you couldn't simply move it to where the consumers were moving. So rules were introduced to allow existing pharmacies to move, to allow for pharmacies to be located with medical centres and in new shopping centres to try and get around some of these problems. There were rural pharmacy subsidies, so a payment if you're a pharmacist in a rural and regional area started up to try and get over and undersupply in those areas. And then at the end of the decade, at the end of the 2000s, we had a thing called price disclosure. And price disclosure was by far the most important thing to happen to pharmacies in the 2000s. What price disclosure did was it removed the source of profits, or largely removed the source of profits that pharmacies had been making, having the price they paid for medicines significantly below the price the government assumed they were paying for medicines. So remember the earlier example, the government assumed the price was, I think it was $43. The pharmacy paid, say, $35, and so there was immediately some profit in there for the pharmacy. What price disclosure did was require the medicine manufacturers to inform the government of the actual sales prices of the medicines, and the government updated its assumed price on the basis of that information. And by doing that, the government was able to remove that profit from the pharmacists and return it to taxpayers. So the benefit of this from the point of view of the medicine supply chain was that previously taxpayers had been paying this money through the PBS, and by moving to price disclosure, it was moved back into the PBS and could be used by government for other purposes. But of course, it hurt pharmacists, it hurt the community pharmacists, because this was a substantial part of their profit. How important was it? In my opinion, far more important than the location rules. Everyone gets excited about the location rules. The big reform in pharmacy was price disclosure. So this gives you an idea of the amount of savings per year through the pharmacy disclosure. Per year if you look at the differences. So the total saving has been upwards of $2 billion between 2011 and the end of financial year 2015-16. So a substantial saving there. Later on, you'll see some numbers for the potential saving from changing dispensing, and over a similar period of time, about half. So this is much more important. Price disclosure put a lot of pressure on community pharmacies. Some community pharmacies have and will in the future go bankrupt because of this, but because they have a valuable license, the license will be sold and taken up by others. The pharmacy rules have again changed over time because of the issues. Whenever you put in regulations, you're going to get issues coming up, problems coming up. Now you can set up a new pharmacy if a demonstrable need. And there's been a significant jump in remuneration per script, which in some ways sort of predictable given that price disclosure is biting. Price disclosure is removing one source of profits. Needless to say, the Guild is out there legitimately lobbying government and saying, hey, you've cut off one source of profits, no free lunch here, we need to get more for dispensing to at least partially compensate for the fact that you've now removed this other source of profits. So the average remuneration per script in the 6 CPA has gone up to about $11.50. Okay, our analysis. What is the appropriation for dispensing? So it's approximately $11.50 per script. We were a bit shocked to find out that when we went to the Department of Health and said, okay, well, what's the basis of this? What costs, what modelling do you use to come up with that $11.50? We were met with blank stares. The $11.50 does not come from any modelling of what it takes an efficient pharmacy to dispense, how to make pharmacy. It comes from a negotiation between the pharmacy owners, the Guild, and the government in this community pharmacy agreement process. Now, that's fine from the point of view of the negotiation, but it's appallingly bad government policy. It's very hard to imagine any other part outside health where taxpayers and where voters would say, look, yeah, the government doesn't know how much to pay these private suppliers. It doesn't know how much it's going to cost them. There is no competition in setting of this dispensing fee. It's a negotiation between the Guild on one side and the government on the other. So the government's essentially negotiating with a monopoly. The government doesn't set different dispensing fees for different banner groups, for example, which it could do to try and get some competition. It just arrives at this figure with the Guild. And it may be too high, it may be too low, may reflect an efficient dispense, maybe under remunerating pharmacists. We don't know. And that's extraordinary. Imagine if the government started building toll roads that way, for example. We're not going to have a contract. We're just going to have a bit of a sit down with the guys who can build this road. We're not going to even think about any other guys. We're just going to negotiate with them and come up with a price. I mean, there would be outrage. But that's effectively how this dispensing fee is determined. And the government doesn't have the data to check it. So you'll see part of our recommendations are to get the data. The government needs the data to actually check that it's providing taxpayers with value for money. Huge differences between the pharmacies. Some pharmacies, about 70% of their revenue come from dispensing, others about 30%. The My Chemist Group, Chemist Warehouse, a lot of the revenue comes from the front of shop, the complementary medicines and the other products they sell. As I said, price disclosure will kill some pharmacies. Our best guess of what an efficient dispense fee would actually be is probably around $8 to $10. But as I said publicly at the time, and I stand by this, I actually don't care about those numbers. I care that the government has the information. If the government got the information and it said that an efficient dispensing fee was, let's say, $16, fine. Pay the community pharmacy $16. The problem is the government has no idea, and that is bad governance. Just to give you an idea, again, of how important price disclosure is, if we went to a $10 dispensing fee based on the data in 2016, saving over 5 years would be about $1.4 billion. Now, remember that we were looking at, 2.3 approximately billion from price disclosure over a similar period. So where price disclosure is, in terms of profits for pharmacies, has been much more important. I've mentioned the variable service that customers get from pharmacists. No modern interface. I've mentioned the paper script. Next time you go into a hospital and they say, what medicines are you on? Think how silly it is that we have that question in Australia. The hospital should know what medicines you're on because there should be a record of them. My health record is starting to fill the gaps, but we're very slow and behind overseas countries. Price variation I've mentioned. The community pharmacy is a shop. They are retailers. And that causes a fundamental conflict because they're also health providers. And I think community pharmacists themselves find that a problem. They find it hard to work out exactly, they know what space they want to be in. They want to be medical professionals, allied health professionals, but they sometimes get dragged down a retail route. This just gives you a bit of an idea of the difference in prices. So, for example, paracetamol plus codeine, when this data was collected, $11.41 was the average price paid, but a standard deviation of around $4.78. So that means you're looking at prices up to around $20 in some pharmacies. Where are the high-priced pharmacies? Well, the best data we had showed that they're rural and regional pharmacies. So these are different geographical locational indicators, the far area locations. As you move right in this graph, you get further out into rural and regional areas. And this is looking at the dollar discount, which can be passed through to consumers by the pharmacist. It's up to the choice of the pharmacist. But essentially, if you live in far area 1, which is close to the major cities in Australia, there's a good chance, not huge, but there's a good chance you'll get a dollar discount. If you live out in rural and regional Australia, the chance you'll get that discount is a lot less, and the prices you will pay are likely to be higher. Location rules, I'm going to skip over some of these because I'm looking at the time. Recommendations, let me quickly flick through these. What did we recommend and what was the government's response? So a minimum set of services that all community pharmacies should be providing. We suggest no pricing discretion. Now, some of people who are economists sort of say, how could you say that, Stephen? I say it simply because the pharmacies are agents of government. It should not be the situation in a health system that whether you can afford your medicines or not, how much you pay for your medicines, depends on where you live. What the government needs to do is make sure there is appropriate compensation, including appropriate compensation for pharmacies in rural and regional Australia. So I'm not at all adverse to the government making those funds get funds, but it runs against the principles of good medicine and good economics to have location determining whether you can afford appropriate medicines in this country. Limits on complementary medicines, happy to get into that in questions. These recommendations were either noted or rejected. So you can still buy homeopathy in community pharmacies, which strikes me as completely odd, if I can put it that way. Electronic scripts. We need electronic scripts. We need a universal health record. We want the situation where if you go to hospital, the hospital knows what medicines you're on. We need the situation where when you leave hospital, it is seamless back to your GP, back to your community pharmacy, so that they know what medicines you're on. And it will reduce medicine misadventures. It will mean people don't get readmitted to hospital for medicine misadventures. It strikes me as a no-brainer. We're slowly moving in that direction in Australia. The other one is the safety net. At the moment, it's calculated manually, which seems slightly odd. If it's a safety net, then it needs to be automatic. That again can happen with electronic medicines information and electronic scripts. They were generally accepted by the government, and we're moving in that direction. The more controversial ones. We recommended, although there were again differences between the members of the review, so two of us, Joe and myself, recommended that there needed to be a lot more information going back to government, so government could understand what it was paying for through dispensing fees. That recommendation was effectively killed by internal panel disagreement. We knew anything that was not unanimous in the final report was pretty much dead on arrival, and this was one that was dead on arrival. But we could not get agreement between Joe, Bill and myself on this one. Location rules. We did look at a recommendation on location rules, but before we got there, the government had said they weren't going to do anything. So rather than have spend time and energy battling it, we said, look, this needs to be looked at by someone somewhere, but not us, because there's no point us doing it. One of the things that concerns us is, particularly in rural and regional areas, there are local monopolies. As new licences become available in rural towns where population is growing, those licences are often taken up by existing pharmacists who operate in that town. So you can go to a town, for example, that will have 3 pharmacies, but they're all owned by the same person. Nowhere else would that be allowed in the economy. I was Mergers Commissioner for 5 years. And believe me, if Coles decided, look, there's 3 pharmacies in town and we're buying up all of them, so out with the IGA and out with the Woolworths and in with 3 Coles, they would be stopped. That's not stopped in pharmacies, but that leads to those high prices that we've already seen. Our recommendations there were noted. Future community pharmacy agreements, and I'll finish on this one because I need to go to questions. We're about to hit the 7th pharmacy agreement and the negotiation there. I said right at the beginning, there are 3 players. Government is really got to deal with consumers, with pharmacists and pharmacy owners. They are 3 separate groups. Only the Guild has been at the table for the previous pharmacy agreements. Really what we need in these pharmacy agreements is to focus on dispensing, on getting medicines safely to consumers, and that means you need both the pharmacist voice, which is the PSA, and the consumer voice. We suggested the Consumer Health Forum. Without those parties sitting at the table, the government will always be negotiating with a group of people, with pharmacy owners, that have a vested interest in boosting the value of their pharmacy. Now, sometimes that's in line with consumer interest, but not always. That's a problem. They were noted. I will note that I think the government has announced that the PSA is going to be part of the next community pharmacy agreement. And some other stuff which I'll skip over. And let me pass over to questions. So, Alison.
Hi,
There we
everyone.
go.
Sorry, trying to get myself off mute. So thanks very much for that. That was really interesting. And we've had a couple of questions come through during your presentation, but if anyone has any other questions, you can either type them in the Q&A section. If you move your mouse on the screen, you'll see a menu pops up at the bottom of it. There's a Q&A button you can use, or the chat button. I'll monitor both of those, whichever one strikes your fancy. So the first question that we had, I'll just go to it here, was really a question of clarification. Dr. King, you said early in the presentation about Chemist Warehouse and that it really accounts for 30% of dispensing. And Paul McKay has asked whether that's 30% of dispensing by volume or by cost to the PBS?
By volume.
By volume.
So, yeah. And it is interesting, consumers pharmacy shop, but they will choose different pharmacists. And consumers often know when they need a bit more information and perhaps want to spend a bit more time. So consumers know which, and I don't want to suggest that Chemist Warehouse don't provide full dispensing services, but consumers know which pharmacists will quit out, get the script out again, and they're doing the repeat, for example, and they say, look, I want to go there, I want to get cheap, I don't want to fuss around, I know what I'm doing, and get out. And other times they will say, well, I want more of the full service, if I can put it that way. And consumers will choose pharmacies according to their own need. Of course, the pharmacies don't get paid differently in those circumstances, and that's a problem.
Yeah.
If you can churn through volume, you're going to make more money.
Yeah, and we see the same thing in GP services, for example, where patients will go to a bulk billing GP if they just need a script refill, but if they actually have something they want to talk to a doctor, they might be willing to travel a bit further or pay a bit more.
Yep.
So that makes sense. Okay, and then we had another question from Senthil about hospital pharmacies in many states and territories dispense a large proportion of PBS medicines to outpatients and also non-PBS medicines within the hospital setting. So how did the review and recommendations impact hospital pharmacy?
Yeah, so we were, to make the project doable, we essentially focused on community pharmacy, and because it came out of the the 6th community pharmacy agreement, our focus was community pharmacy. We did interact at various stages with hospital pharmacies, and we certainly talked to numerous hospitals and to numerous hospital pharmacies and saw their operation, because there is a key interaction that goes on there. A couple of issues that came up, one that I've mentioned, and I can't mention too strongly in a sense, is the issue of making sure you have that seamless system into hospital, out of hospital, with regards to your medicines, quite frankly, with regards to other services as well. In the mental health review that I'm part of at the moment, we see the same sort of problems with patients discharged from hospital and being back in there within 2 weeks because they haven't got appropriate support. We see the same with medicine misadventures. So that connection between hospital and community is vital, and it isn't working very well. The other one, actually, in the Indigenous space in particular, the difference, because hospitals are state, the PBS is federal money, sometimes, and it's worst in the Indigenous space, where an Indigenous consumer can have a script from a hospital and they're under one system of support for filling that script, and then if they go into a community pharmacist, they actually can't get that support, and so have to pay a higher price, and it's a mess. And one of our recommendations is, look, when you're supporting consumers, it's got to be consumer-centred. It has to follow the consumer. This consumer shouldn't have to worry about, oh gosh, is this a state script or a federal script? But unfortunately, they do at the moment, or at least Indigenous Australians in particular have to.
Okay. Oh, great. So then there's another question from Kevin DeVries, which is I guess in a similar vein, which is around rurality for pharmacy programs. So did you consider the suitability of PHARIA, which is PH and then ARIA, as a measure of rurality for pharmacy programs? And if so, what did you find? And would there be other methods that might be more equitable or more effective?
Yeah, so we didn't look at the PHARIA classification in particular. We used it because that's the one that the data's in. There was a movement away, certainly when we were looking at it, towards an alternative, which I think was called the Monash model, the Monash approach, something like that, which I assume came out of Monash University somewhere, rather than Sir John. We didn't look at the particular details. There's always going to be limitations when you put lines on maps. It can't be helped. I think the key issue that I'd like to stress is with regards to those rural areas. So wholesaling to one side, and as I said, I'm happy to answer questions on wholesaling, but given time, I don't want to go down there. On the consumer pharmacy side, there is a shortage of community pharmacists, particularly in remote parts of Australia. And there's a straight workforce issue. We were talking to a pharmacist in Weipa, for example, who could not get a pharmacist up to their pharmacy in Weipa. They were paying well under, they were offering by far the highest salaries that we'd heard in Australia. They were offering housing. I don't know if they've managed to fill the position, but it had been vacant for quite a while when we talked to them. We heard similar stories or similar issues of hiring in other parts of Australia. One of our approaches to get around that was, and we hoped that it was targeted, which was in remote parts of Australia, and these are often areas where there are Indigenous communities. There is no pharmacy, there is no pharmacist, but other countries have dealt with that issue through machine dispensing. So you see machine dispensing in remote parts of Scotland and remote parts of Canada, and it works very well. So we did put in a recommendation about trialling machine dispensing where there is no pharmacist, and quite frankly, there's not likely to be a pharmacist. That was rejected by the government, and that was probably the most annoying rejection, in the sense that the stated reason by the minister was that, well, we're not replacing pharmacists with machines. My response is, these are people who need to be able to access medicines and they can't, and that's I view it as unacceptable.
Mm-hmm. Okay, and I think Claire Freeman had a similar question around PHARIA categories and inadequacies, so hopefully that's answered hers as well. So Christy Weir has a question, which I'll just read out. So this is a quote. "It sounds like price disclosure should have been brought in a long time ago. And I'm unsure why pharmacies should ever have received more money from the government than they paid for a medicine. So now pharmacies have lost this profit, which in my opinion, they shouldn't have received in the first place. And the Guild is lobbying the government to make it up elsewhere. Do you have any comments on the political power of the Guild?"
Yeah, I don't think any, I'll say two things, particularly on the Guild. One is the Guild is a very, very powerful lobby group. They're a very successful lobby group. Sometimes it's viewed as, it's so you're against the Guild. No, I mean, we see lobby groups everywhere. We see lobby groups in airlines, we see lobby groups in banking, we see lobby groups. So we should not be, there's no judgment of the Guild, and the Guild has been very successful and for its members. The issue, though, is the consequences. And the consequences of the Guild's success means that if you owned a pharmacy, and you still own your pharmacy, if you owned your pharmacy in the early 1990s, you have made very good profits over the last approximately 30 years, and you own a very valuable asset. Now, that asset's not as valuable as it was before price disclosure, because price disclosure has taken out some of the profit. If you're a young pharmacist, though, to own a pharmacy, you essentially have to buy an existing pharmacy. You have to buy that license from an existing pharmacy. So there were effectively a lot of middle-aged white guys who were pharmacies in the 90s. There weren't many women pharmacy owners back then. The young pharmacists coming out today, we came across examples where they had paid multiple millions to be able to get into a share of the pharmacy. And so the problem now is for the pharmacists is that if you owe the bank, say, $2 million to buy into a pharmacy, and the guild isn't successful in keeping your profits up, the bank's not going to say, well, your pharmacy is not worth that $2 million anymore, we're going to forgive your debt. You're going to be paying money out to the banks because you had to buy that license whilst your profits are getting squeezed. And I call it the taxi license. We saw taxis, we saw the issue with licenses, we saw the stress that put, and there were a significant number of suicides of taxi license owners because they had $1 million debt and an asset worth almost nothing. That's a risk in pharmacies. So, it's something that community pharmacy needs to deal with. I think the PSA and the Guild need to work out how to deal with this going forward. It's very easy to sit there and say, well, we've got the profits built into our license. Let's try and keep the profits up by hook or by crook. Eventually, it will collapse, and it's going to hurt a lot of young pharmacists. And that, I think, is, for pharmacists themselves, that is the biggest issue in the industry. Long term, these location rules hurt the pharmacists often more than the consumer.
Okay. Oh, that's interesting. Now, I'm conscious of time, but we've got quite a few questions. So I'm just going to pick one more to ask, and then perhaps I can send them to you, or you can have a look at them, Stephen, and maybe email people or something if you've got some answers to them. But one which I thought was interesting is Agnes Vitry has said that in some countries, they actually require the recruitment of a new pharmacist when a pharmacy reaches a certain sort of level of dispensing per day. And this rule seems quite effective if you want to ensure the quality of dispensing and having time available to provide counselling services and for consumers to have that across all pharmacies as standard. And so what do you think about such a rule being applied in the Australian context?
Yeah, so I mean, there are recommendations on the number of pharmacists that you have in your pharmacy for the number of scripts. Look, it may go some way towards helping, but pharmacies all face the same situation. They face different flows of scripts during the day. So you could have 10 pharmacists in there who are twiddling their thumbs for half the morning, half the afternoon, and at lunchtime. And I'm thinking about a CBD, for example, they're flat out, and even 10 can't cover the business. And so they're trying to get the dispensers done as fast as possible. A pharmacy that has the same number of dispensers over a day, but they're spread evenly over a day, may be able to have 5 pharmacists and offer fantastic service. So we are aware of those sort of models. We did think about them. We think in the Australian context, with the big level of variation between pharmacies, but it's probably not advisable to try and come up with a simple rule like that. Our approach was more to say, let's set standards for the pharmacies in terms of what services they have to offer, in terms of dispensing, in terms of the other products they provide, in terms of the information to consumers, and let's require that with appropriate auditing. And so rather than trying to define the inputs, if I can call it that way, say what are the outcomes that we're after, and let's try and get to those. And we thought there was a better approach in Australia.
Okay, that's really interesting. Thank you. So I'm sorry we don't have time to get to all of the questions this afternoon because there's some really interesting ones, and obviously the presentation, you could talk about these rules and regulations and competition and unintended consequences all afternoon, I'm sure. But thank you very much, Dr. Stephen King, for your presentation today, and thank you everyone for joining us. As Sarah said, the presentation will be available on the Health Services Research Association website. And I would also just like to echo Sarah's encouragement that people who have enjoyed the presentation today might be interested in joining the Health Services Research Association, and also to consider submitting an abstract for the conference, which is coming up at the end of the year in New Zealand. So thanks for that. And Sarah, I don't know if you want to do any closing comments?
No, it's all good, Alison. Thank you. Thanks, Steve.
Thanks, everyone.
Thanks, everybody.
Okay, bye.
Thank you, Alison and Sarah. Thank you.
Thank you.